Good afternoon, Mr. Chairman, members of the committee. I thank you for the opportunity to be here. My name is Linda Peeno, and although the witness list does not reflect this, I am a physician. I'm a former medical director and medical reviewer. I did the job that was referred to repeatedly in the first panel as a physician manager for 3 healthcare organizations. I currently, though, primarily work in medical and healthcare ethics. I am here primarily today to make a public confession. In the spring of 1987, as a physician, I denied a man a necessary operation that would have saved his life and thus caused his death. No person and no group has held me accountable for this, because in fact what I did was I saved a company $500,000 for this. And furthermore, this particular act secured my reputation as a good medical director, and it ensured my continued advancement in the healthcare field. I went from making a few $100s a week as a medical reviewer to an escalating 6-figure income as a physician executive. In all my work, I had one primary duty, and that was to use my medical expertise for the financial benefit of the organization for which I worked. And according to the managed care industry, and I think we've heard intimations of that today, and we've seen this in at least 2 cases, it is not an ethical issue to sacrifice a human being for a savings, no matter how that savings occurs. And I was told repeatedly that I was not denying care, I was simply denying payment. I am not an ethicist whose primary background has come from the books. For me, my ethical issues were born in the trenches and fed by the pain that I have come to realize that I caused. And if I am an expert here today, it's because I know how managed care maims and kills patients. So I'm here to tell you about the dirty work of managed care. And this is the kind of straight talk that I wish Ms. Ignani could hear now. And let me explain to you the ways that I was a good medical director. I was regularly consulted by marketing on ways to change expensive benefits or change the language to give me loopholes to make denials when requests came. For example, in one plan, we were able to structure our investigational language exclusion so that I was often able to use it to deny just almost anything that was expensive and particularly out-of-network request. I turned pre-existing exclusions into a game, and as I tried to connect almost any prior medical complaint or visit as a reason to deny payment. There are many more things that I could tell you about, but ultimately I was only as good, and I put that in quotation marks, as the doctors in my network, for it was their numbers that I needed to prove that I was doing my job. That meant that I did whatever it took to control them. Intimidation, hassling, humiliation, I have done it all. I have used inadequate and inaccurate data to create reports to get doctors to make their numbers better. In other words, decrease their usage. I have used economic credentialing to select the best inexpensive physicians and rarely correlated these with quality factors. I have helped design contract provisions to ensure our payment and monitoring schemes got the results we wanted at the plan. And I have threatened deselection to numerous physicians who were especially difficult or costly. However, there is one last activity that I think deserves a special place on this list, and this is what I call the smart bomb of cost containment, and that's medical necessities denials. Let me take you to the heart of managed care. Even if a plan denies all the other things that I could list, it is impossible for them to deny their use of this practice because it's vital to managed care. That's making medical decisions about access, availability, and use. And even when medical criteria is used, it's rarely developed in any kind of standard traditional clinical processes. It's rarely standardized across the field. The criteria is rarely available for prior review by the physicians or the members of the plan. And so even if a plan has a clear benefit package and has all the perks like free eye exams or free screening tests for cancer, other marketing ploys, the member's physician will never be the final authority on what his or her patient will get. And this might go unnoticed for simple needs like a regular office visit or a bout of the flu. But I can tell you that when something unexpected or expensive happens, it's like a bucolic pasture-turned battlefield. The landmines will start exploding everywhere. And somewhere in every coverage booklet for every managed care plan is a claim that establishes the plan as the final authority for making determination of medical necessity. And what this means is that there is some physician at some plan doing what I did. That person rarely is continuing a clinical practice. They're sitting behind a desk making decisions about a patient they will never see or touch, completely removed from the consequences of their decisions. They're getting paid by someone to make decisions for the benefit of the plan and not for the benefit of the members. I'd like to conclude by saying, what kind of system have we created when a physician can receive a lucrative income for adding to the suffering of patients? I became a physician to care for, not bring harm to my patients. And I'm haunted by the thousands of pieces of paper in which I have written that deadly word, denied. Thank you.
Thank you, Dr. Ms.